Hello guys, today we are going to talk about mitral regurgitation, what we will cover during this lecture. Definition, general classification, etiology, pathology, clinical features, diagnosis and treatment. So first let's start with some heart anatomy. The heart has four chambers: right atrium, right ventricle, left atrium and left ventricle. Then we have the tricuspid valve. Between the right atrium and the left ventricle, we have the mitral valve, which has in two cusps between the left atrium and the left ventricle. And we have the pulmonic valve, which is located between the right ventricle and the pulmonary artery. And we have the aortic valve between the left ventricle and the aorta. So, cardiac cycle, it starts when desoxygenated blood comes from superior vena cava and inferior vena cava into the right atrium. It gives blood into the right atrium, and this blood goes from the right atrium to the right ventricle through the tricuspid valve. Then it passes through the pulmonary valve into the pulmonary artery, where it gets oxygenated in the lungs, and it comes back through the pulmonary veins into the left atrium, and it passes from the left atrium into the left ventricle through the mitral valve, and after that it goes into the aorta through the aortic valve, and it goes into the other organs and tissues in the body to give us nutrients and to give the organs what they need of oxygen. So mitral regurgitation. Mitral regurgitation, it happens when there is a leakage. It's also called, by the way, mitral incompetence or a mitral insufficiency. It happens when there is a leakage of blood from the left ventricle into the left atrium during systole due to an incomplete closure of the mitral valve. It's categorized according to the onset as acute, chronic, and according to the etiology as primary and secondary mitral regurgitation. So an acute mitral regurgitation, it means that the mitral valve, when it's has this regurg when the mitral valve has this acute dysfunction, it leads to a volume overload and symptoms of acute heart failure because the heart will not have time to compensate as in a chronic mitral regurgitation. So for the chronic mitral regurgitation, the heart will have time to compensate. And this occurs through cardiac remodeling through changes within the heart, which will affect the heart's ejection fraction, systolic function, the cardiac output, and it will lead eventually to heart failure. So speaking about the etiology, so for the primary mitral regurgitation, it's called also, by the way, organic mitral regurgitation, even though this is not used. We call it only mitral and primary or secondary. So for the primary mitral regurgitation, it's caused by a direct involvement of the valve leaflets or the chordae tendineae. The main causes include degenerative mitral valve disease, for example, like a prolapse in which the leaflets they bulge into the left atrium, which creates space so that this blood um, it creates a space, and this blood during systole it leaks from the left ventricle into the left atrium. Or it can be due to some annulus calcification or some due to ruptured chordae tendineae. It can be due to infective endocarditis, rheumatic fever, ischemic mitral regurgitation, for example, like after an acute myocardial infarction leading to a rupture of the papillary muscles. For secondary or functional mitral regurgitation, it's caused by changes within the left ventricle, which leads to a valvular incompetence, for example, like coronary artery disease or a prior MI causing papillary muscle involvements. It can be due to dilated cardiomyopathy, like peripartum cardiomyopathy as well. This can be due to amyloidosis, systemic lupus erythematosus, Now the clinical features, but before the clinical features, let's talk about some pathology. So what happens in the acute mitral regurgitation? Uh, it leads to increase in the left atrial volume with a normal left atrial compliance and increase in the left ventricular and diastolic volume. And this will lead to increase in the left atrial and the pulmonary pressure, and it leads eventually this pressure it leads to pulmonary venous congestion, which is presented as a pulmonary edema. For the chronic mitral regurgitation, it can be either compensated or decompensated. So for the chronic compensated mitral regurgitation, there is a progressive dilation of the left ventricle, and this is what I call the cardiac remodeling. So what happens is an eccentric hypertrophy of the left ventricle due to this volume overload from the blood, and there will be increase in the capacity of the left ventricle, while the preload and the actual load they return to normal values because of this increased capacity of the left ventricle, and there will be increase in diastolic volume. And these changes they don't affect the stroke volume, and they don't affect the ejection. They don't affect, the ejection fraction. It will stay normal, and it maintains increased stroke volume. For the chronic decompensated mitral regurgitation, there is a progressive left ventricular enlargement and myocardial dysfunction, and there will be, due to that, decreased stroke volume and increase in the end systolic and end diastolic volumes. It will lead also to an increase in the left ventricular and left atrial pressure, which will lead to pulmonary congestion and possibly acute pulmonary edema, pulmonary hypertension, and right heart strain with time. So speaking about the clinical features, for the clinical features in acute mitral regurgitation, patients will be presenting with dyspnea, symptoms of left-sided heart failure, and symptoms of a pulmonary edema, like crackles and palpitations. In severe cases, there will be cardiogenic shock with poor peripheral perfusion, tachycardia, tachypnea, and hypotension. In auscultation, on auscultation, there will be a soft decrescendo murmur. No murmurs of severe regurgitation with left ventricular dysfunction or hypotension. And for the chronic mitral regurgitation, there will be also dyspnea, including exertional dyspnea and dry cough, fatigue, palpitations, symptoms of left heart failure, including, for example, pitching edema, and potentially also for right heart failure as well, which includes presence of ascites, hepatomegaly, splenomegaly, jugular venous distension, and hepatojugular reflux presence, patient edema as well, or perisacral edema in case that the patient stays in bed. For auscultation, we will have a holosystolic murmur, high-pitched blowing, which radiates to the left axilla and it's best heard at the apex. And its intensity, it can be either increased by a preload, increase in the preload, for example, like raising the legs of the patient, or it can be increased due to increase in the afterload, like a hand grip, because if we do that, there will be increase in the regurgitant volume. And also there will be a lateral displacement of apical impulses on auscultation. For diagnosis, first of all, lab investigations. For lab investigations, we have to check troponin levels first, because they may indicate a myocardial ischemia if they are positive, as we know that acute mitral regurgitation is caused actually primarily by acute myocardial infarction. So we have to check troponin levels. We have to check also BNP and NT pro-BNP, which is normal in acute settings of mitral regurgitation and increased in chronic mitral regurgitation. We can check blood cultures, especially if we suspect that the patient has some form of infection like infective endocarditis, and general CBC. For ECG, we can check in acute mitral regurgitation. There will be either non-specific signs or some ST and T wave changes, especially if it's caused by MI. And we can check also for atrial fibrillation if it's present. For chronic mitral regurgitation, usually we will see signs of left ventricular hypertrophy, Mitral, and here you see a picture. It's like a biphasic P wave, which is present on D2 or even on V1, and it indicates a left atrial enlargement. We can check also for atrial fibrillation, it can be present too, and signs of right heart strain in later stages. Signs of right heart strain, it includes P pulmonale, and P pulmonale, it's like a peaked P wave. And then we can do transthoracic echocardiography because it's the main diagnostic actually for mitral regurgitation or any valvular pathology. If we hear a murmur present in the patient during physical examination, we have to do echocardiography, and mainly transthoracic echocardiography because it's much easier than esophageal echocardiography. We can do also X-ray to check for a presence of pulmonary edema and to rule out also other causes of dyspnea like pulmonic causes, and to check for cardiac remodeling changes like left atrial enlargements. We can see some calcifications present. Additional tests include cardiac MRI. It's used mainly for suspected cardiomyopathy